Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this clip, I'm going to represent cases with different ejection fraction without wall motion abnormality from 20% to over 75% ejection fraction by using the technique we called it visual guessing or eyeball guessing ejection fraction. If on the previous clip I explained those rules and tips and tricks. If you haven't checked it out yet, go first review that one and then come and watch it this one. At the end, after this presentation, I'm going to prepare another clips about visual guessing ejection fraction in those cases, arrhythmia, especially AFib. And after that, another one maybe about those visual guessing on when we have wall motion abnormality or other situation. Now let's go for this one. This is very obvious over 75, even over 80. You can see even at the basal view, at the level of basal, almost completely closing, and at the papillary muscle level, it's almost kissing, it's over 80. Since we don't have wall motion abnormality, even with these three uh, clip, if we can guess it how much it is ejection fraction, 70 to 75%. But in next page, next slide, I show the other view. Here, the same patient in apical window, those three view. Again, all these cases, assuming almost they don't have wall motion abnormality. Here, the same patient in apical views. As you can see here, this is tracing is wrong, overestimating, and very obvious. As a general rule, as I mentioned, any time, first of all, when especially in apical 2, we will have a little angling, small fanning up and down. It go off axis. When we are going to do Simpson in apical 2, doesn't matter apical 4 or 2, attention, make sure your view is correct, apex, and always goes to the bits that has largest size at the end diastole and end systole, not this one. As you can see here, at the systole, that bit, the apex is almost there, even is kissing and contracting, but all the way goes up. And here we have some thickening, looks like thickening. Here we have epicardium. As you can see, this is artifact. And if you go frame by frame, you can see and trace, you can see differences. This is the real endocardium and not this one. Just go frame by frame when you go measuring for Simpson is very important. Find the endocardium, real endocardium. It's the same patient, so ejection fraction is 65 to 70%. Same patient apical window, and ejection fraction 60 to 65. The normal regular. Here, just you take attention here. It become between 2 and 4, so off axis measure on this one. Make it clear, no papillary muscle, no right ventricle. Here I want to mention something about the ejection fraction with the technique, as you can see here. Generally speaking, I explain in other lecture on the plaques is not this technique for the plaques is not good. If we don't have wall motion abnormality, the best and more reliable take technique is on the P-axis. How we do it? We go between the tip of the mitral valve and papillary muscle, this view, and then we go make sure it is completely circular shape. Then we go measure left ventricular internal diameter in diastole at this level. Then we go at the same beats, we go at the systole. Then it will be much more reliable compared to the plaques. So if you have good window, measure for the take technique on the P-axis, not on the plaques. Here the same patient in the apical window with measurement. Here, if you attention, you can see a little too much discrepancy between apical four chamber and apical two. And if you go attention, you can see here overestimating. Uh, as you can see, epicardium is here, and basal, we usually basal segment is equal to the mid or even thinner. And here is overestimated. It goes should go out at the border. It come here, not here. So this is overestimating. That is the reason you can see too much discrepancy between these two. And here, opposite way, we are underestimating the endostolic volume. It goes a little outer, exactly contact with the endocardium. So, and here a little go out. So the combination of those, this is too much underestimating, this is overestimating, but if you correct it, usually they are very close, 3%, almost 3% differences between them if we don't have wall motion abnormality. Many situations, especially for those cases that the ejection fraction decreased, and for follow-up, post-surgery, post-valvular, or after pacemaker, or this synchronization, or post chemotherapy, then that we are preferring measure accurate number, not the range of 5%. So in those cases, it's better we have to be very careful on our measurement, and then we mention exactly our measurement by Simpson in the apical 2 and 4. Here is that one the exactly is not below, here is exactly around 50%, not 45, not 55. Is almost around that 50%, maybe 48, 49, and 50 to 52. In those cases, we can mention exactly the number we calculate if our measurement at window and view is correct. Even though here is a little, you can see on this case, basal, uh, anteroseptal, and mid hypokinetic. And this patient had a stent. Here, the same patient on the contrast, with the contrast, as you can see, we have clear border. We can do Simpson on the touch, and the contrast is better, but you have to remember again those landmark that we have correct view. Otherwise, 100% we will overestimating. As you can see in this view, is not two chamber, is between two and three, between two and four. Even sometimes off axis become five basal view. So it's a little bit tricky when you do contrast and make sure patient hold his or her breath when you do contrast study and get correct view, then we can do it Simpson on the with the contrast. This case belong to the same patient, 50%, 45, 50%, 40 to 45%. 35, 40%, same patient apical views, here again you can see a little overestimating or underestimating about the tracing. Here a little, as you can see, in the diastolic and in systolic, even a little we have ball motion abnormality, but tracing is a little in off here, and here a little you can see basal. Especially one of the most important mistake is putting that the exactly hinge or ring of the mitral valve, because a little changing during the isosystole is not the same spot. 100% our ejection fraction will be wrong. Here we didn't have a very good window for the apical, so we used contrast, as you can see. Ejection fraction 30 to 35% measured with the contrast. The next case, here the patient has paste, and so on the paste we have some septal abnormality. I am going to talk about that in another lecture. Next one, 25 to 30%. So our last case, 20 to 25%.